So welcome to my channel. We are discussing today arterial blood gases. The first thing when you look an ABG strip, you would be watching at a partial pressure of oxygen, which is PO2. And why this is important? Because this will tell you whether your patient is going into respiratory failure or not. If the PO2 is more than 80 up to 100 or even more when he's on oxygen, you would think more that the patient is not in respiratory failure. But if it's going less than 80% and even less than 60%, you can surely say that your patient is in respiratory failure. So what type of respiratory failure, whether it's type 1 or type 2, we can discuss it later on. So the first thing you will be looking in the ABGs would be a PO2. Next important thing would be to look at the pH. Normal pH of blood is between 7.35 to 7.45. Remember the level. So anything below 7.35 would cause an acidosis, and once the pH is increased more than 7.45, it is alkalosis. So pretty basic thing. The next looking at would be PCO2, the partial pressure of carbon dioxide. Why this is important? Because once we are looking at the pH and whether it's acidosis or alkalosis, what kind of pH is that, the next will be to correlate with PCO2 and bicarb. Which one of them is causing the pH to go up or down? So PCO2, it's acidotic. CO2 is acidotic. Once it's increased, it will cause acidosis, but when it is decreased, it will cause alkalotic effect. A normal value of PCO2 is easy to remember as the normal pH was 7.35 to 7.45. Just removes the 7 and you know that the PCO2 normal value will be 335 to 45. Next thing, very important, would be bicarbs. Normal value of bicarbs would be between 22 to 26. So as bicarb is, you can know by the name, it's an alkali. Once it is increased, it will cause alkalosis, and once it is decreased, it will cause acidosis. So how do you determine which acid-base disorder it is? It's easy. You have to look at the pH, then compare the pH with the PCO2 and the bicarbs, and see which one is causing the pH change and which one is compensating. Now, and once you have determined which one is compensating, you have to see whether the compensation is adequate or not. So in a metabolic disorder, you will expect the PCO2 would be obviously compensating as compared, and the causing effect, and that is, changing the pH, would be bicarb. In the respiratory disorders, normally it's the PCO2 that is drifting the pH up or down, and the bicarbs are compensating. Okay, and the other thing would be important to calculate the anion gap. As we know the anion gap formula, what do we do is we calculate sodium and potassium, then you subtract it from chlorine and bicarb. So let's go with an interpretation of the ABGs. Question number 1. You're seeing a patient who's a 54-year-old lady on the ward. She's 3 days post cholecystectomy and has been complaining of SOB. Now these are the ABGs that we're looking at. pH is 7.49, PO2 is 7.5. PO2 is 7.5. The patient is in respiratory failure. Now look at the pH. pH is above 7.45, which is alkalotic. So the patient has alkalosis. Which one is it? Whether it's respiratory alkalosis or a metabolic alkalosis? Now look at the PCO2. The PCO2 is down. Once the PCO2 is down, it is according to the pH, because down PCO2 will cause alkalosis. So as the pH is alkalotic, so that means the PCO2 is according to the pH. So this is the one that is causing the pH to go up. So it is respiratory alkalosis. Now the next step would be to look at bicarbs. we're seeing at the bicarbs and they are pretty normal. So that means the patient has respiratory alkalosis but with no compensation, almost no compensation, as this is an acute process. This has occurred in 3 days only. Usually the compensation takes at least 7 days or more, so the compensation has not yet occurred. So this is a respiratory alkalosis without compensation. Okay, so these kind of things usually happen when the patient is breathing too much, too heavily, when hyperventilating. When you hyperventilate, you lose PCO2, and there are multiple differentials that can cause all that. One of the top differential would be pulmonary embolism. This is so here one important thing is that this patient has a respiratory alkalosis and the patient has PO2 of 7.5. So the patient has a respiratory failure as the PCO2 is below 6, so it is a type 1 respiratory failure. Type 1 respiratory failure. If the patient had PCO2 more than 6, then we will call it a type 2 respiratory failure. Okay, so bear that in mind as well. So looking at the question number 2, let's look at these. A 75-year-old gentleman living in the community is being assessed for home oxygen. His ABG is as follows. Now look at this pH. pH is 7.36, which is almost in the normal range, but it is up at the level of somewhere between 7.35, close to 7.35. So that means this pH is being compensated. It was in acidosis previously, but it is somehow compensated. Now, look at the PCO2. It is very, very high, 7.6. And high PCO2 is technically in line with the pH. So it's the high PCO2 that was causing the pH to go below 7.35. So that was respiratory acidosis. But look at the bicarbs. The bicarbs are also high. As the bicarbs are high, you know that the bicarbs are alkalotic, but the pH is still in the acidotic range or close to acidotic range. So that means it's not the bicarb that is driving the pH, it's the PCO2 that is driving the pH down. So it was a respiratory acidosis, but as bicarbs try to increase it to keep the pH within the normal range, so it is a compensated respiratory acidosis. A compensated respiratory acidosis. So question number 3. A 65-year-old gentleman with a history of COPD presents with worsening SOB and increased sputum production. They're looking at this pH. We can clearly see it is in acidotic range, and we see the PCO2 is here very high as well, 8.5. So high PCO2 will cause acidosis, and it matches with the pH. So it is respiratory acidosis again. Look at the bicarbs. Bicarbs are in the alkalotic range. They are increased. So they are trying to compensate the acidotic pH, but they are not able to compensate completely. pH is still very low. So this is not compensated. It is a respiratory acidosis that has not yet compensated. So it is an acute respiratory acidosis. A 21-year-old woman presents feeling acutely lightheaded and short of breath. She has her final university exam next week. Let's look at the pH of this young lady. pH is 7.48, which is alkalotic. A PCO2 of 3.5, which is low. That means that keeps in view of the, PCO2 is down, which is down PCO2 is equal to alkalosis, and the pH is also alkalotic, so it matches with the pH. So this is still respiratory alkalosis. But looking at the bicarb, they are still normal. So the patient is having respiratory alkalosis, and carbs have not yet started to compensate. So that means this patient is hyperventilating, like our previous first case. So this is respiratory alkalosis, which is not. Question number 5. 67-year-old man with a history of peptic ulcer disease presents with persistent vomiting. It is, as the stem is quite obvious, somebody is persistently vomiting. So this is something, it is going to be metabolic. because it has nothing to do with respiration. We can see the pH, it is in the metabolic range. We look at the PCO2, it is in the normal range. Look at the bicarbs and they are very high. So this means this patient has metabolic alkalosis. It is the bicarb that is causing the pH to go up. So metabolic alkalosis, but the PCO2 is not compensating. So that means it is acute metabolic alkalosis and the lungs have not yet tried to compensate. And how would the lungs would compensate? They would try to increase the PCO2. They would try to keep the PCO2, preserve the PCO2, so it will rise and it will eventually compensate the pH. The differential diagnosis here are very clear. Any cause of vomiting, diarrhea, anything that will cause metabolic alkalosis. Okay, so a roughly approach would be looking at the ABGs, whether the pH is in acidosis range or alkalosis range. And then when you see that it's acidosis, you have to make sure whether it's metabolic acidosis or respiratory acidosis, looking at the PCO2 and the bicarbs. And then you look at the compensation. Okay, this is important. In the same, if it's alkalosis, you have to make sure whether it's metabolic alkalosis or respiratory alkalosis and look at the compensation. Thank you so much for watching.